record. So I have to say, of like all the lectures, this is probably my least favorite. It probably will be one of yours too. So super excited to have to record it so that we could watch it again later. Because if there's something health professionals don't like talking about, it's malpractice. Okay. So this is our topic for today, malpractice and risk management. We're going to talk about what gets PAs sued, how we can hopefully identify strategies to avoid this situation, and talk about the elements of a malpractice suit. So oftentimes we hear that the first thing that happens when anyone is notified that they are being sued, kind of like the steps of grief, you go into shock and denial and ask yourself, why is this happening? Because we all think that if something goes awry, we're going to know about it and it's going to be expected, but data tells us that is not true. It is not often the case that had all of the red flags. It oftentimes is something that you didn't even remember happening that seemed fine at the time. So then you go into the shock. This can't be happening to me. I'm in shock. I don't believe it. I'm too young for this to happen to me. My career is going to be over. I don't think I did anything wrong. And you find that you have climbed on an emotional roller coaster. Because just like PA school is a whole different experience than other school, and going to the clinic and going to hospital is a completely foreign environment until you get in there and get used to it. All of the proceedings of a lawsuit are foreign to us. It's not an environment that we're comfortable in being with. They're using new terminology that we don't know. They have different training and expectations. And an alleged lawsuit has a significant impact on your life and your practice. Someone is questioning your ability. Very likely that's going to make you question your own ability and question everything you do. And this typically is a pretty long process from the time that someone is first notified that they've been involved in a lawsuit till the whole thing is done. Can often be 3 to 5 years. And in the meantime, you're supposed to continue going about your daily work, taking care of people. And during that time, there's often worry about, what do my coworkers think? Do they think I'm incompetent? How do they feel about this? What if I have to see that person again, or their family member, or someone else who's involved in it? So what are the most common reasons that a PA might be involved in a lawsuit? First one is something called lack of adequate supervision. So you have to ensure that you are following the legal requirements of whatever state you are practicing in. And there may be certain details in certain states about supervision requirements, how often you have to meet with the person supervising you, how often they have to review your work. But even beyond that, if there is something going on in a particular patient encounter that falls outside of your ability and experience, and you don't get assistance, whether it's from a supervising physician or a specialist or an ER person, and document that, that also can fall under lack of adequate supervision. Can sometimes, even if you do it, you need to definitely document the chart notes. So if I'm just not sure what's happening, I have a person in and I'm concerned about their vision. They're having eye pain and I'm not sure what's going on. And I call and talk to the ophthalmologist, and I tell them symptoms they're having and the findings, and we discuss a treatment plan. Then I need to put in my chart, in consultation with Dr. Jones, this was discussed, this history, this exam, this was the assessment we came up with together, here's our plan. Needs to be in the know. Kind of plays back into how important an S-bar is, that you be able to not only put that together and use it to call the specialist, but then that you document, I called, we discussed in this S-bar, this was our plan, it gets in the know. Second one, untimely referral. So this could include, again, just a discussion with a consulting person. It could include sending that person on to emergency room, to urgent care, to a specialist. It could even include something like not sending them for labs or diagnostic testing in some cases. That could be counted as untimely referral, that you should have ordered a chest x-ray or got them set up for an echocardiogram and you didn't. Third one is failure to diagnose. So this could include misinterpreting findings, not catching a finding on an x-ray, not interpreting a lab finding correctly. It could be uncertainty about a particular diagnosis. It could be someone with an atypical presentation of an illness that you don't find. A person that doesn't follow an expected recovery course, that appropriate follow-up isn't done. So any of those things that should prompt documentation, consult, further follow-up, and doesn't happen, can fall under failure to diagnose. Inadequate examination. So I know Professor Jar is pounding into you inspection, auscultation, palpation, percussion. Leaving one of those elements out, or not including the appropriate body systems that need to be included in the examination, can result in the finding of inadequate examination of the patient. And doing your own exam, not relying on what the person who saw them yesterday said, but repeating those findings. Lack of documentation. So the question you should be asking yourself is, if someone reads this 6 months from now, 2 years from now, 5 years from now, would they get an accurate picture of the care that I provided today? Or would there be missing information that would tell them that, yes, I did this exam, yes, I asked that question, yes, I considered that diagnosis, and here's why I did or didn't do specific testing. This includes both positive findings and negative findings, like we've talked about in ClinMed, documenting even if they said they weren't having it, that I asked that question and they told me they weren't having that symptom or that thing. If it's not in that documentation, then you're not going to be able to defend that you actually thought about it, did it, asked it. And then the last one is lack of communication. This is one of our main reasons for topics class, where we're learning all of these communication tools and where communication falls apart and barriers to communication. Because if you didn't communicate the reason for ordering a test and they don't look for the right thing, if you didn't communicate to the patient what should trigger follow-up, if you don't have good communication between you and your rest of your healthcare team and you don't get the findings you need, that can result in big problems. So we've talked about that extensively in topics class. So what can we do to protect ourselves? First of all, we have to really be clear on our documentation. Even if we did it, if it isn't documented, then we can't prove that it happened. The record is our legal proof of what we did to the patient, what we did for the patient, and it is our communication to the rest of the healthcare team about our clinical reasoning process, our exam findings, what we asked on our review of systems, and our plan and our documentation of what we educated the patient about. So we need to make these things just very routine. Every day, every patient. I think the thing that we tend to fall into once we're out in practice and we're busy is, like, if there's a case that we have some reason to suspect that there could be a problem. So if there was an unhappy patient or something where we felt like, wow, this is a risky thing, this could go bad, like, we'll do an awesome job of documenting that one. But then the other 23 patients of the day, like, we don't pay that same attention to it. So we need to make this just very routine, very part of our everyday, every patient practice. It's ultimately going to result in better patient care, and things are less likely to fall through the cracks. So sticking with making sure and thinking through that we're really doing a good SOAP notes, that we're documenting all of our education plans, and that the patient, we asked follow-up questions and they understood what we were saying, recording all of our conversations and phone calls with other providers, with specialists, not using those potentially misinterpreted abbreviations, making sure it's really clear. We have to document our discussions with patients, results of phone calls, making sure when we document our history and our exam that we addressed all appropriate review systems things. That's kind of the skill we're practicing in OSCEs. How do we pull out those right review systems and make sure we're asking all the appropriate questions? Things like when your electronic medical record gives you an alert when you prescribe a medication or when you order something, when you dismiss it. Some EMRs ask you why you're dismissing it and document that. Some don't. And then you need to think about that yourself, saying, I got an alert about this medication. It was okay to prescribe because patients tolerated it before, or whatever your reasoning is. And then being really transparent with our patients. When patients don't feel like they're being communicated well with or things aren't clear, It's when they tend to get confused, upset, angry, and that's priming them for feeling like they've not been well taken care of, or their family members. So making sure that they have a way to see their test results. They may see your notes and that they need to be really clear in there. Any messages that you're sending back and forth in a portal. You want to use very objective, observed language, unambiguous. It's very clear. We talk about this in topics as well. So interpersonal communication. When we're with the patient, we need to, and their families, we need to be truly present. We need to make sure the door is closed, that we're not having other distractions going on, and that we're really listening. We want to be professional so that we're not complaining about things going on in our own lives or in the office to the patient. We want to treat their family members and their significant others with respect and kindness. Usually when they're in a situation that they're in seeking care, it's because they're concerned and they're worried. Don't make promises you can't keep. One of the physicians I work with closely, I got on him on this all the time. He would promise them lab results tomorrow that I knew full well weren't going to come for 4 or 5 days. And that's just setting people up for frustration when they haven't gotten results that you're not going to get back yet. Or don't promise that they're going to get into dermatology next week when you know there's a 6-week wait to get in. You say, right now there's a 6-week wait. I'm going to try to talk to someone, especially if you think it's something that deserves to jump the line, see if I can get you worked in sooner, get you on a cancellation list. I'm going to do everything I can to advocate for you. I'm going to talk to someone about your case, so at least I've talked to them about it ahead of time. But don't make promises, pie in the sky stuff. Talk to people in language that is respectful and that they can understand at their level. And the more you are able to treat people the way you want to be treated, the more likely they are going to also treat you the way you want to be treated. These are all taken from Ruth Baldwig's PA textbook. I have this at the end. One of our early leaders. We want to make sure that we're really treating things confidentially and professionally. We have access to private and sensitive and personal information. Sometimes you may have family members or other people trying to get that information and may even misrepresent that they have been given permission to get it. Like, really make sure you're checking your EMRs for who has permission to have access to that information. Kind of one of the classic examples is somebody goes in for a pregnancy test, family member knows they went in, they call and ask about the result. You want to make sure that they have permission to get that information. This again is from Ruth Baldwig's text, so things that are keys to communication success. I thought this one was really interesting. Providers who spend less than 15 minutes in a room are more likely to be sued than providers who spend 18 minutes. 3 minutes difference. Taking that extra couple minutes to really make sure they understood everything that happened. Providers who use humor and laugh with their patients are more successful in patient communication. I think this is just like being empathic and has less to say about whether you're a good joke teller as opposed to, are you in tune? Do you kind of set the tone, make people comfortable? Do they feel like they can ask you what they want to ask you? Do you take that few seconds at the beginning of the appointment to kind of take the temperature of the room? You walk in the room, is that person sitting there with their arms folded looking all upset? Or are they looking relaxed? Or are they looking really anxious? That can tell you a lot about how you want to open your interaction with them. Really explaining things well before you do it. This is something I know Professor Jar and you guys are practicing all the time. I'm going to touch this, I'm going to do that. And then just encouraging your patient to communicate back to you. Asking at the very least at the end before you walk out, is there anything you don't understand, anything that you have questions about? And even better if you can do it kind of at each step. When you're done taking the history before you move on to the exam, when you're done taking the exam before you verbalize a plan, giving them a chance to kind of catch up every time. Showing a lot of compassion, especially in those really difficult conversations, when things aren't going well, when you're giving difficult diagnoses, when you don't know what's going on and you're trying to get answers. A lot of times people are afraid to apologize when things have gone poorly because they're afraid that's admitting that they're guilt. If you know you're about to walk into a situation where things have gone badly, consulting ahead of time with your department chair or risk management, what can I say? Is it okay? A lot of times it's okay to say, I'm really sorry this has happened. And that doesn't necessarily mean it's your fault, but you're just taking the time to say, this sucks. This is really bad. We're really sorry this is happening. And there's been some studies to show that if you are able to do that, that can make a huge difference. Oh, I think this slide was supposed to go back earlier. So again, electronic health records, there's a lot of awesome things about them. There's a lot of places where they can unintentionally lead you astray, using templates without actually thinking through, does this template include everything I really need for this situation? Has this documented all of the pieces that I just did? Being careful when we're using drop-down menus, it's so easy to click on the wrong thing. So just double check, taking that time to double check, make sure you got it. And then, like I mentioned before, when those warnings pop up, and you guys haven't had a chance to really see or deal with that, but a lot of times you'll just get this pop-up box when you prescribe a medication that there's a chance that it could interact with something else they're taking, or is there a chance this person could be pregnant if you're prescribing this? And when you're busy, it's easy to just dismiss that when you in your own mind know why it's okay or why you think it's okay to dismiss it. But if you haven't documented in a way why you did that, that can be risky. So with malpractice, there's something called discovery rule. So the statute of limitations that a person has to bring a lawsuit, that timeline doesn't start until that person has awareness of the occurrence of the event, when they should have known that something went wrong. And that's when the timeline starts. So, for example, if there was a surgery and a foreign body was left inside the patient's chest, a tool or a towel or something, and it wasn't found until 7 years later when that person died and they did an autopsy and they found it, The statute of limitations starts at the time of the autopsy when the mistake is found. It doesn't start 7 years earlier when the mistake was made. An average claim takes about 22 months to report and about 34 months to resolve, so a total of about 55 months. So the 4 parts of the typical medical malpractice situation. First part is duty. So this is the implied contract between the healthcare provider and the patient. You are assuming as a healthcare provider duty to treat with care and skill of a competent provider in your situation. Breach occurs when the care provided falls below the accepted standard of care. There are 2 standards of care that may apply. There's an internal standard of care, so one set within your own clinic and your own health system, that this is the process we have for reporting out a result, or this is the process we have for doing a referral. There can also be an external standard of care, like a national standard. So for example, the American College of OB/GYN has standards for interpreting a pap smear that are a national standard set by them. So if you are reading pap smears, you are held to that external national standard of care, as well as your own internal standards of how do you communicate abnormal pap results to patients? What's the protocol? There's causation, which means they have to show that the healthcare provider was not following a standard of care, was negligent, and that the result of that resulted in some kind of injury or damage, which is the next part. So the last part is types of injuries or damages. So there are injuries like disability, deformity, chronic pain, death. They experienced additional medical expenses, lost wages, out-of-pocket expenses. There's some intangible ones, pain and suffering, emotional distress. And then punitive, like fraudulent or malicious treatment of a patient.
Can I ask a question?
Mm-hmm.
Every once in a while, I hear someone say, this is how you do it in the real world versus this is what you know for the test. Is that different than a violation of an external standard of care? Is the things that we're learning for like the pants, is that considered necessarily an external standard? Does that make sense?
It's a little different. So like on the test, when we usually in a situation like that, we might be talking about like, this is how you typically, what you typically would order to confirm this diagnosis. But the pants wants to know, what is the gold standard? You might not typically do the gold standard because it's a test that is really expensive or is very, causes a lot of pain to do that. So you may not typically do that gold standard, but you still need to know what the gold standard is. These standards are, external standards are usually national guidelines. Sometimes there may even be national guidelines among different associations that are different. And so you may need to document, like, I'm following in our clinic or hospital system, we're following this guideline for prostate cancer screening. And as long as you have a nationally accredited association that doesn't have a major flawed system and is well accepted, there may be 2 or 3 different standards out there. As long as you're consistently following the one that your organization has chosen, or you can document your reasons why you followed a different one, at least you show that you've thought about it and you're following a standard. Okay. So some National Practitioner Data Bank data. The overall incidence and ratio of malpractice claims per provider has not been shown to be any greater for PAs or nurse practitioners than for physicians over a 17-year period. The average and median malpractice payments of physician assistants were less than those of physicians over that same period, while that of nurse practitioners ended up to be greater than physicians. The trend in median payment increases was less for PAs than for physicians and nurse practitioners. So data, there's a few more. Adding a PA to a practice did not negate their cost effectiveness to the practice by adding more costs of malpractice. The rate of malpractice incidents for PAs and APNs over that study period remained steady for physicians, but was consistent in the change in number of active providers. And the reasons for disciplinary actions were similar across all groups. So what we can take from that is national practitioner data does not show that PAs are practicing any riskier medicine, which hopefully should be reassuring that we are doing a good job. Hopefully that means we are being taught well in what we're doing. Okay. So we're going to do a couple case studies. Originally, this was in the syllabus as a assignment that you guys were going to do. Because you have a brief quiz today in topics, and I really try not to give you out of class work for both topics and professional issues at the same time. And because malpractice stuff is not like, I would like to discuss this all together as a group. As long as I feel like we're all kind of getting something out of this, participating in it, we're going to make our in-class discussion today be your assignment. So we're going to do an in-class assignment today. Okay. Oh, I got to bring something else up here. Just a second. I've got a little bit more information on these cases than what I could fit on the slides. I swear I need like 3 screens. And these example cases too are from Ruth Baldwig's text that she wrote for us. Okay, so this first case. So this is a case actually of a cattle rancher. So for 3 days, this rancher was moving cattle from one pasture to another. On day 2, he began having chest pain while he was working. And then he would rest and take a break. And when he was like driving in between the two locations, he was not having any chest pain or associated symptoms. On day 3, while working, the severity of the chest pain increased and began having nausea without vomiting, shortness of breath, and diaphoresis. Around noon of day 3, he decided to go into the urgent care center, which was about 5 miles away from where he was working. Because he showed up at noontime, he was very fortunate. There was no one else in the waiting room at urgent care. And so he was taken in right away and seen by the PA that was staffing the urgent care. There was a physician in the center, but that physician was on their lunch break. So in the urgent care center, it was noted that this was a 50-year-old white male having classic substernal chest pain that began with exercise. And now on day 3 was having nausea without vomiting, diaphoresis, complaining of radiation of pain to left jaw and left arm. His blood pressure was 160/98, pulse 110, respirations 24, temperature 101.2. They did an electrocardiogram, and there was ST elevation in limb lead 2. He was diaphoretic and looked anxious. PA recognized that the patient was having an MI. He immediately got word to the physician who was on their lunch break to come out, and the patient was given an aspirin, started on IV fluids, and a nitroglycerin patch was placed. They had the nurse call 911, and they were preparing to get the patient transported as soon as the ambulance came. They also put in a call to the local hospital to notify them that there was a patient with an MI who was going to be en route. And by the time the patient was being transported, he was in stable condition. Unfortunately, that night, the patient had a second MI and died in the hospital. So the patient's wife and 3 teenage sons sued the PA, the urgent care center, and the physician, saying that the PA did not follow the standards of care for treatment of an MI. They had failed to transport in a timely manner, and that the physician didn't see the patient. Can't remember. Oh, no, that's the next case. Okay. So during deposition, it was determined that, in fact, standard of care of treatment of an MI was followed, that the PA did see the patient in a timely manner. They were diagnosed quickly, an accurate history was taken, appropriate examination was done and documented as it related to an MI, and that the electrocardiogram had been correctly interpreted, and that the transfer occurred in a timely manner. And because of all of that documentation, the PA was exonerated. The patient's wife stated during her deposition that when she arrived at the urgent care center, she had talked to the physician in the exam room when he was called in to be with her husband, which then disproved the claim that the physician was not notified and did not see the patient. She also stated the timeline of when the transport occurred, which helped prove that it was done in a timely manner. So the physician was also exonerated. So this shows positive outcome, that doing a good history, good physical exam, making the correct diagnosis, making sure that a appropriate consult was done and pulled in. 911 had been called, the hospital had been notified. So all those 6 issues had been satisfied. As far as timely referral, communication, all of those things have been done. It was well documented, and it was good evidence that the patient was already stable when he was transported, that they had done a good job. Okay. Case 2. So this case is a 64-year-old white male who was walking on his treadmill at home. He was accustomed to doing this routine for the past several months, had never had any problems on the treadmill. However, on this date, he'd been walking for approximately 15 minutes, developed sudden onset of back pain in the right lumbar area with radiation to his right side buttocks, right hip, and right posterior thigh. It was sharp and severe enough that he had to stop walking on the treadmill. He wasn't having any numbness, tingling, or weakness of the lower extremities, and wasn't having any problems with bowel or bladder function. He took 2 Tylenol, but did not get any better. The next day, he made an appointment in clinic and wanted to see his primary care physician, but that person was unavailable, so instead was seen by the PA. PA obtained the following information. Chief complaint was back pain with radiation to right buttocks and right leg. History, sudden onset of back pain with exercise to radiation, with radiation to right hip, leg, and buttocks. No relieving factors. Pain was worse with bending and leaning forward. Tylenol was not helpful. No prior history of back pain. Exam. PA recorded that there was a right-sided lumbar spasm. Reflexes were equally bilaterally in the lower extremities, some pain in the right buttocks, posterior thigh with palpation. And it was recorded that he had some difficulty getting on and off the exam table and walking. He was assessed to have right lumbar strain and right muscle spasm and sciatica. They gave Toradol 10 milligrams injection, was prescribed Lortab, 1 tablet every 4 to 6 hours, moist heat to the right area of the lumbar region 4 times a day. Rest for 24 hours, not to get back on the treadmill until recovered, follow up as needed. Next day, patient's no better. He had no relief of his pain with that previous treatment. He was again seen back in the same office, but this time by the PA covering the walk-in clinic. The family primary care physician was out again at the office this day. So noted by the second PA, he recorded that he first reviewed the record from the day before. Took a history, back pain was not improved, no numbness, tingling, or weakness of the lower extremities. There was no abdominal pain, no bowel or bladder changes. Previous pain medication not helped. Did an exam, recorded as essentially unchanged from the day before. He had lumbar spasm and sciatic notch tenderness. Reflexes were equal bilaterally in the extremities, lower extremities. Difficulty with ambulation, getting on and off the exam table. Assessment was right lower lumbar muscle spasm with right leg sciatica. So essentially the same diagnosis as the day before. Plan, given another injection of Toradol, added Flexeril, 1 tablet 3 times a day, return as needed. Next day, patient passed out at home. 911 was called. He was taken to the local hospital. On evaluation, paramedics suspected he was having a ruptured aortic abdominal aneurysm. Despite resuscitation attempts with massive fluids and CPR, he was pronounced dead 20 minutes after arrival at the emergency room department. Patient's daughter was an attorney who filed a medical malpractice suit within days after the funeral. So my question to you is, which of those reasons that PAs get sued apply to this case?
Untimely referral.
Untimely referral. Neither of those PAs ever consulted with any other specialists, other physicians. It turned out that there were actually, even though that particular patient's primary care provider was out of the office, there were other physicians and other providers in the office at the time the patient was seen. He was never referred to the ER or for any kind of imaging. What other things?
Like an incomplete physical exam, if they were just looking at his leg and lower back, they didn't check some other areas.
Mm-hmm. So inadequate examination. So, and this part I would not expect you guys to know right now because we haven't discussed abdominal aortic aneurysms. But in a patient over 50 who has back pain, you need to do an abdominal exam. Or at the very least, if they would have checked pulses, not just reflexes, but pulses in the lower extremities. In the case of an aortic aneurysm, pulses are probably going to be diminished or absent.
Doesn't Toradol also increase your cardiovascular risk as well?
I think in some cases it can. Any of these other 6 reasons apply to this scenario?
I guess failure to diagnose could fall in.
Yep, failure to diagnose.
I feel like lack of communication, like partly because they didn't think through the like bad can't miss differentials, but they also like didn't communicate that with the family. Like it could be these other things. Here's what to look for.
Mm-hmm.
And probably lack of adequate supervision since the physician was out of the office and they weren't being like seen over.
Mm-hmm. So they didn't consult with the primary care physician, although they were out of the office, or any other provider in the office that was there. And in this case, it was also cited for inadequate history. So they had not taken a complete history, and had not discovered that this patient's brother had died of abdominal aortic aneurysm just a couple of years earlier. He was a longtime smoker of 2 packs a day, which is a significant risk factor for development of aortic aneurysm. First PA didn't even ask about any abdominal symptoms. Second PA did ask about abdominal symptoms, but because the patient said he wasn't having any, they didn't do an abdominal exam. So sometimes just because the person isn't complaining of it doesn't mean you don't do that part. So the result of this case, both PAs ended up being named in the lawsuit. The plaintiff ultimately won this lawsuit. For one of the 2 PAs, it was the second successful medical malpractice case against him, and therefore was unable to obtain any other malpractice insurance coverage and was forced to change professions. The physician was also successfully sued for inadequate supervision. And according to the National Practitioner Data Bank, the award in this case was well over $1 million. And again, this was probably a case where people are thinking, oh, it's back strain, send him on his merry way, probably never see this person again.
So you said that the supervision or the supervising MD was also sued. What should he have done to not have been like sued, I guess? Like obviously he wasn't there. Should he have had someone in his place then, thoroughly communicating or going over all the cases when he got back? I guess, I don't know, kind of off topic. But.
Yeah, I mean, so maybe there weren't enough protocols set up for a protocol if someone comes back for back pain that's not responding to treatment, that there should be potentially a protocol that it's at least discussed with someone else. The other part of this is just because it was a successful lawsuit doesn't necessarily mean that that person really did something wrong.
Okay. Yeah. Thank you.
That's the reality. Because outside of maybe having a protocol for that particular situation, I don't know what else the physician could have done when they weren't even in the building.
I'm kind of curious about how the new laws might affect this in Minnesota. Do you think that PAs are going to be at higher risk of malpractice suits with less physician supervision?
So the data would suggest that there shouldn't be any increased risk of suits. However, there may be less risk for physicians being named in a suit like this if they weren't directly involved.
Thank you.
So here's my references. There was a presentation on 5 strategies to reduce, or an article on 5 strategies to reduce lawsuit threats, which I kind of referenced, and then those cases and some of those advice were directly from Ruth Ballwig's book. All right. You may all consider your malpractice risk assessment assignment completed. And I will enter that for you all. I think this is an excellent time to take a break until 11 o'clock when we'll pick this back up.